Anyway, it is very delighted to be invited to these wonderful sessions. In the next about 20 minutes, I will talk about the importance of basic for ultrasound guided ablation. Thanks to the many Asian pioneers on tumor ablation and also many members from Asian Society of Tumor Ablation, we made sound evidence on curative ablation for HCC, as you can see. There are many papers, including the representative paper from Japan, so-called self-study. As you can see, there was no significant difference between surgical resection and radiofrequency ablation, even for recurrence-free survival. So ablation is accepted as a curative treatment option for early stage HCC, including the AFSUMB and Korean guideline. Again, ablation is a curative treatment option for early stage HCC, even if surgically resectable. However, only tumor size and number are mentioned in the most treatment guidelines to assign the proper weapons for the battle against HCC. Any weapon cannot guarantee the best patient outcome if we don't use accurately and smartly. Besides the tumor size and locational numbers, many more things should be considered for the best outcome of our ablation. So it is time to get a consensus on strategic optimization of ultrasound-guided ablation. Strategic optimization involves a personalized methodology beyond conventional practice. By incorporating advanced technology and tailored patient care, we can boost precision and procedural efficacy. Individualized treatment plans guided by advanced imaging enable accurate tumor delineation and minimize collateral thermal damage. This is a proposal for standardization of terms and reporting criteria, but now we need more practical recommendation for liver ablation. Recently, Korean Liver Cancer Association initiated to prepare the expert recommendation for liver ablation. This guideline includes all essential parts on liver ablation, including indication to post-ablation assessment. We will submit this document in JLC, so you can see maybe in this year. So moving on, strategic optimization. The first, careful selection is the most important. For careful selection, we need to understand the pros and cons of local ablation. Careful selection of the best candidate is the first door to successful ablation. Beyond location, we should consider many more factors, including patient, tumor, and operators. So many factors. As we all know, the best candidate of local ablation is a single, smaller than 3 centimeter, well-defined conspicuous tumor, non-perivascular, non-subcapsular, and non-perihilar tumor. Carefully select the enemy that you can clearly kill with a single shooting. It is very important. The magic bullet for careful selection is the multidisciplinary approach. Please discuss with your colleagues to decide the final decision. This is our study. You can see multidisciplinary approach can improve the survival of our patient. Secondly, precise planning. After careful selection, we need precise planning to achieve best outcomes. As we all know, planning is almost half for successful ablation. We cannot build this kind of gorgeous building without the detailed planning. Please decide all the details in advance at your planning phase, including approach, position, guidance, energy source, ablation parameters, assistance technique, and finally combined treatment with TASE, etc. And also we need to define the target ablation zone with optimal ablative margin, 5 to 10 millimeter. And also we have to expect the potential complication from immediate and delayed complication. Depending on the potential complication, we need to prepare to prevent this kind of complication. And also we need to rehearsal any procedure in mind and refine the plan. And also please make a document on the older detailed plan in your medical record. Again, precise planning is almost half of successful ablation. Moving on, accurate ablation. It is time to move from just bigger and faster ablation to more accurate and optimal ablation. Accurate placement is the most critical part for successful ablation. Punctual placement of applicator, like Swiss watch. So this should be our goal. Everything, tiny everything is critical, even from the skin puncture side. Choose the best applicator path for the best configuration of ablation zone and optimal ablation volume. Before starting ablation, please ask yourself, is it accurately placed? Are you sure? Ask yourself 3 times. If the answer is clearly, surely yes, at that time, push the button. This is very important, especially for ultrasound guidance, because as we all know, sonic window must be getting worse after starting ablation. For accurate and safe ablation, we have many solutions, novel technique, including fusion, contrast-lens ultrasound, and artificial fluid. There are so many papers proving the benefit of fusion and contrast-lens ultrasound to maximize the therapeutic effect and provide safe ablation. Novel is really necessary. If the index tumor is inconspicuous or any potential of thermal injury, we should consider to use fusion, CUS, or artificial fluid. Let me show our 2 cases briefly. One is artificial ascites. We don't use spinal needle, we use angiographic catheter sheath to make artificial ascites. It's more convenient than just needle. The tumor is located dome lesion. To select the peritoneal space, I use this kind of technique. Subcapsular insertion at the breathe-in state. After then, I instruct the patient fully expirate. If so, the tip of the sheath usually placed in the peritoneal space. So at that time, I insert guide wire and replaced with dilator. So you can see very tiny guide wire, very narrow peritoneal space, and then replace the angiography introducer sheath. And we can infuse artificial cells very rapidly in 2 to 3 minutes. Okay, Sony window clearly improved in 2 to 3 minutes. As you can see, such a tiny tumor can be seen clearly with ultrasound guidance, and then insertion of the electrode toward the tumor. And then we mark the tumor with a yellow circle, and ablative margin, target margin, indicated a red circle. So after starting the ablation, we have to wait. Echogenic ablation zone is approaching the red circle. That means enough ablative margin. And also, we can clearly prevent a thermal injury to the diaphragm like this. And needle cauterization to prevent bleeding and tract seeding. Compared to laparoscopic ablation, this is minimally invasive, isn't it? Pre-ablation and post-ablation in 5 minutes. Moving on to the second case about artificial pleural effusion. There are 2 recurrent tumors in segment 7. For artificial pleural effusion, we prefer semi-erect position to minimize the fluid. We use the 17-gauge epidural needle. And you can see artificial pleural effusion can improve the zone window dramatically. And first ablation from deep-seated lesion, and then move to superficial lesion using the no-touch technique. So pre and post-ablation CT. So artificial ascites or pleural effusion is a really essential technique. Moving on the optimal ablation. So optimal is better, just excessive enough ablation. So please save the liver, because don't forget the poor liver, because many more treatment will be surely coming near the future due to recurrent tumor recurrence. HCC continuously recur until the end of patient life. The moving on the post-ablation assessment. Please take your time to evaluate post-ablation imaging. We need to evaluate ablation zone itself, whether it is optimal, excessive or insufficient, or residual, and ablative margin, circumferential or eccentric, or is there any immediate complication. And also please have a time for self-Q&A session. It is really important process to learn something from each case. Placement of electrode was really accurate. Ablation zone is similar to your plan. Was it excessive or insufficient? Why? What about ablative margin, circumferential or eccentric? Why? Any mistake compared to your original plan? Any unexpected event? Any complication? What did you miss at the planning or procedure? How will you do if you have the same patient next time? And finally, what is the single lesson from this case? We already know well, but sometimes we forget. Please compare the post-ablation result with your original plan and find any difference between the both. After that, think about the reason. Please write down what you have done well, what you have done wrongly, finally, what have you learned from the case. Please repeat what you have done well, and please don't repeat any your first mistake. And finally, please share the lesson with your colleague. Finally, basic forever. Recently, we are living in the era of immunotherapy. So, how do you think the future of ablation in the immunotherapy era? There are so many studies are ongoing regarding combined treatment with ablation and immunotherapy. Local regional therapy, combined immunotherapy, or adjuvant immunotherapy after local regional treatment. So many studies on immunoablation are ongoing. I'm looking forward to seeing the promising result soon, hopefully in 10 years. Don't forget the success of ablation, almost all procedure depends on the basic rather than novel technology. Basic, we already know well, includes careful selection, precise planning, accurate and optimal ablation, and post-ablation assessment. Novel technology is necessary for the better outcome, including fusion, CUS, artificial cysts, immunoablation, robotics, even AI. However, the novel is sometimes useless if you miss the basic. So ablation is the most minimally invasive and cost-effective, and also we have excellent outcomes for 20 years. So liver ablation finally survived in the most treatment guideline, as you can see. So now it is time to deep positioning in the ablation box. So in my conclusion, basic is more important just novel technology. Thank you for your attention.
Thank you, Dr. for your excellent lectures and beautiful pictures and demonstration. It's time for discussion.